Health Education England supports the delivery of excellent healthcare and health improvement to our patients by ensuring that our workforce has the right numbers, skills, values and behaviours at the right time and place. In the North West, the Workforce Transformation Team funds initiatives that develop a responsive workforce by developing future supply, upskilling staff, carers and volunteers, and developing and promoting new roles and ways of working. This video, featuring a new medical assistant role, is one in a series of case studies exploring innovative and transformational ways of working to share and promote entrepreneurial workforce development across the system.
So the role of medical assistant really came out because I was conscious I was dealing with mainly older patients. In Southport and Thornbury we have a very high proportion of over 65s and over 75s. Consultations tend to be more complex because older people have more long-term conditions. And I was realising I was actually doing quite a lot of things in the consultation that I didn't need to do. And as a result of both the complexity of the consultations and the amount of tasks that consultations generated, I was running behind time. It felt like I was trying to squeeze, 3/4 of a day work into half a day, and the role really sprang from that.
The job role was offered out to administrative staff, and it was basically a role that would be working alongside Dr. Leonard, assisting him when he's in clinic with his patients, but doing a lot of the admin side of things. I basically thought, well, it's a challenge, it's working closely with the GP, it's getting to know the patients a little bit better as well. We do have over 3,000 patients. And I just thought it'd be really interesting.
The mentoring's usually fairly informal, but at the end of the session we often have a little bit of a debrief and we'll talk about some of the things that she wasn't quite so sure about, and we'll have a chat and that'll inform it for the next session. But usually the patients, when they come in, because we know what they're coming in with, I can actually direct Claire to the areas that she needs to concentrate on. As well as the informal mentoring, we've done some formal training such as phlebotomy, immunisation, and there are plans to do ECGs and spirometry in the future. So when I first thought of this role, I knew I'd have to convince my partner and my practice manager that it would be a good idea, because there was going to be an upfront cost implication relating to it, and also it introduces a different quality of service when I have Claire with me than when I don't have Claire with me.
When Dr. Leonard first suggested it, I was probably quite negative about the role, just because I wasn't sure how we were going to look at the financial side of things, plus the role that we originally were looking at was to bring maybe someone off reception, so I was thinking that we were going to end up being understaffed on reception. Now the role's been running for 6 months, probably the entire team feels completely different about Claire's role. Specifically for myself, I've seen Dr. Leonard be able to operate in a more efficient way, run his clinics more to time, have that backup from Claire and just offer a better patient experience.
According to Health Education England, we're slightly unusual in the North West in that we have a slightly higher percentage of administrative staff, 7% compared to the national average, and a slightly lower percentage of HCA staff, 6%. The good thing for us is that actually there's probably a pool of administrative staff that actually could fulfil the role of a personal medical assistant.
As a medical assistant, I will call one patient in, get a background on that patient as to why they're here. We do have this protocol now where we do ask the patient what their symptoms are and things before they actually book the appointment, so we do have that background knowledge as well. If blood pressures need to be taken, I will do that, any pulse, weight, height, things like that. And just a general chit chat really as to why they are here, and then I can relay that information to Dr. Leonard.
Once the patient story is presented to me, I can check it, do whatever I need to do, and there's always going to be some task that I can actually then delegate to Claire.
The patient is normally quite happy to have me there. I do explain what I'm doing there in the first instance when they do see me, as opposed to Dr. Leonard, and it puts them at ease as well really. So they do like to have a chat with you, and then when Dr. Leonard does come in, I just take a step back. I can relay the information as to why they're here, and then he will do the full consultation.
So it's working really well. On the days that Claire's with me, my surgeries are running pretty much to time, and I'm certainly enjoying my work a lot more. I think it's got great potential in terms of its maintaining my enthusiasm for my work, and it will certainly keep me in my job longer. For administrative staff like Claire, it diversifies their role and opens up career opportunities. And from what I've seen, it certainly benefits the patient experience.